for this first rounds, first of all, thank you for inviting me to do rounds. It's very exciting. I spend a lot of time alone in my office, so it's nice to actually get to engage with people, even digitally. So, so thanks for inviting me to do this. I'm super excited. I can talk all day about cytology and cool cases, and I have about a million slide boxes full of cool cases. So I've been thinking about what kind of themes I can do and all this stuff. So it's pretty fun. But for this first rounds, I love infectious disease, so I wanted to talk to you guys about some cool infectious disease cases. I tried to keep it relatively short because I tend to overtalk, and I think it's worse to talk too long than too short. So it may be a little short, but we'll see how it goes. Hopefully it'll be good, a good length. But for any of you guys who don't know me, our Blue Pearl interns know me, but my name's Kate Baker. I'm a clinical pathologist, and I work in a Blue Pearl. I work for Antech, but I work inside of a Blue Pearl, hence why I'm doing Blue Pearl rounds. And I'm originally from Tennessee. My husband and you guys, I know Jaime knows Will, but for anybody who doesn't know Will, he's the ER manager. I don't know what his official title is, but he's an ER vet, and he does all the management stuff for the ER and also the interns. So we are from Tennessee. I'm from Nashville. He's from a little bit farther south of Nashville. Went to UT for vet school, and then went and did a one-year rotating internship in Nashville at Nashville Vet Specialists, and then came to Illinois for my residency for 3 years, and now we're back in Louisville, and we've been here for 3 years because Will did his internship at Blue Pearl in Kentucky. So kind of full circle, but yeah, so we love it here, and yeah, enough about me. Talking about yourself is awkward, so I'm just going to go on. Okay, so I know that it's kind of hard to pick something that everybody's going to see, especially ER and intern, but these cases are relevant to you guys. Actually, these cases came in, I think, primarily on ER, if not all on ER. So they are things that you might see. So let's dig in. So this is the first case. This was a case, Will, I think that this was your case, wasn't it? You can shake your head yes or no. I don't know. Can you hear me? I see your face. Okay. Okay, good. Yeah, this was Will's case that came in on the ER. It was a 5-year-old golden doodle, not this golden doodle, but that is a cute golden doodle. And he presented with hyperexia, bloody vomiting, and bloody diarrhea and vomiting. So not super specific, but he was quite sick. He really was not doing well when he came in, and obviously even somebody like me who doesn't see animals anymore could tell that something was wrong with him. And on exam, is everything okay, Will? Yeah, okay. He's messing. It looks like he's messing with some controls on their end. On exam, he was obtunded, so again, pretty sick looking. He had pale mucous membranes and bradycardia. They did some blood work and saw that he had hypoalbuminemia. He had a pre-renal azotemia from dehydration, and he also was showing signs of DIC because his PTT was prolonged, and he also had thrombocytopenia. All right. So radiographs. I am not a radiologist. It's been a long time since I've looked at radiographs. So Jaime, no, this one, I had my notes next to me so that I could remember what was in the radiograph. I think there's some ileus and the loss of serosal detail, and then there was also a little bit of, there was concern for free air, I think it was, and then there also was a little tiny bit of abdominal effusion. So clearly these guts are very pissed off. But the question is why. So the first thing that was done diagnostically was to try to get a little bit of that abdominal fluid. And that's why we're talking about this case, because we're going to look at abdominal fluid. So this is a sample from the abdominal fluid in this dog. I know it's a real extreme close-up, but you can see, I hope you guys can see my cursor. So these cells here, these are all cells. All this red stuff, this is all blood. But these cells are almost hard to tell exactly what they are because they are just kind of falling apart. And sorry, I have a new puppy, and she's playing with a water bottle. So yeah, so all these cells are. Anybody have any idea what these are?
Bacteria.
Well, there is. Yeah, that's right. You got it. There is bacteria, but what are they in? What cell type are they? Are the bacteria inside this guy? What cell type might eat bacteria? Anybody?
We have votes for macrophage and degenerative neutrophils.
Good. Yeah. Good. So macrophage. This one might be a macrophage. I'm not. I don't really know. Honestly, I think it probably is, but he's kind of falling apart. A majority of these are very, very degenerate neutrophils. So good job. Degenerate neutrophils can be really tough to identify when they get so degenerate because their nucleus can get so puffy and weird that it's hard to tell even what it is. And that actually happens in urine a lot, infected urine, where the neutrophils almost look like lymphocytes because the nucleus gets almost a little bit rounded out because it's so degenerate and puffy. So remember, degenerate, what constitutes something as a degenerate neutrophil is that the nucleus becomes very puffy and almost looks like it's been injected with water. You don't see those crisp nuclear segments like you do with it. Oh, what? Sorry, one second. Hear y'all? No. Oh, are you trying to fix the volume? I don't think, or I might be able to. Blue Pearl, y'all say something. Oh yeah, I can hear. Yeah.
Hey.
Okay. Yeah. Now don't say anything else. I'm watching you. But yeah, so degenerate neutrophils are that's the characteristics of them cytologically is that they have that puffy, swollen nucleus. Just a side note, don't call them toxic because toxic neutrophils are what we call changes when we are seeing things in the blood smear. So when we're out in the tissues and we see that appearance to neutrophils, they're called degenerate neutrophils. And anytime we see degenerate neutrophils, we definitely want to look for bacteria because even though it doesn't always mean there's going to be bacteria there, it's a very strong clue that you should be looking for bacteria, especially in cavity effusions. So in this case, this was a no-brainer. I mean, we didn't have to look for bacteria long at all, obviously, because there was bacteria everywhere. These guys are rods here, and then we've got these really weird, I've seen these a few times. I guess it's some type of a gastrointestinal bacteria that looks like a boomerang, but nonetheless, that's a weird bacterium. And then these rods. And so this is definitely what we call septic, suppurative, or septic neutrophilic inflammation. So the dog has a septic abdomen. And one thing to remember is that we want to see bacteria inside the neutrophils before we make that call, just because if you see bacteria outside of the cells, it might be contaminant from your stain. It might just be some type of weird debris that looks like bacteria. So we really want to see it inside the neutrophils. Now, if I saw a dog that had an abdominal effusion that was wall-to-wall degenerate neutrophils, and I only found like a few extracellular bacteria, I'd still be like, ooh, that might be a septic abdomen. We're just happening not to find the bacteria inside the neutrophils. So use your context clues in your clinical information. So this dog was taken to surgery naturally because of his septic abdomen, and this is what they found in surgery. So I know you all are oohing and awing in your head. I am not a surgeon, but even I can tell that this is not good. So does anybody have any ideas what this is?
We have a vote for mesenteric torsion.
Good. Excellent. Yeah, so this is a mesenteric torsion, and this dog's intestines were, I think this is dead. I think this counts as dead or close to dead. Not right is what I would call it, but yeah, it's definitely diseased intestines and secondary to a mesenteric torsion in this case. So unfortunately, as you guys can imagine, he was euthanized. So a nice sad case to start us off this lovely morning. Any questions on that case? All right. Well, if you have them pop in, don't be shy. So case 2, This is Pepper. She was a 9-year-old, or is, I'm not sure if she's still alive or not anymore, but 9-year-old female spayed dachshund. And she came in just lethargy, not herself, so ADR, nothing really specific in her clinical history. And when she was examined, they saw that she had a fever, and she also had uveitis and generalized lymphadenomegaly. So what are some differentials that you would consider if you had that come in on emergency?
Fungal, tick-borne.
What was the first one? I heard tick-borne.
Fungal.
Fungal, good. Tick-borne, good. One more big one that I would probably put on my list.
Lymphoma.
Yeah, good. Excellent. Yeah, so those are really good ones. So fungal, we're all in the South, so we all see fungal here. And tick-borne is definitely one to consider as well. I don't know, would tick-borne cause uveitis? I guess it can. I'm not sure if it would or not. Yeah, no?
We have votes for yeah.
Okay. I don't know really much about eyes, so that I believe you. And then generalized lymphadenomegaly is something that all of those can cause as well. Excellent job. So what are we going to do next? So we might aspirate the lymph nodes, right? So that's what they did. And I apologize, this came out a little bit grainy, but this is an aspirate from one of the lymph nodes. So she had generalized lymphadenomegaly, so they ended up aspirating several lymph nodes, but this was the first lymph node that they aspirated, and I had all of the lymph nodes, but this was the first one that I put up on my microscope. And so just a real quick some tips for looking at lymph node cytology. So what should a lymph node primarily be made up of? What cell type?
All of the sites.
Lymphocytes, good, yeah. So it should be mostly lymphocytes, and they should be mostly, I think you said small lymphocytes, which is correct. So a normal or reactive lymph node should have primarily small lymphocytes, and then when they become more reactive, you can see more intermediate to large lymphocytes and plasma cells come in. When you are dealing with large cell lymphoma, you'll have the reverse of that. So you'll have primarily intermediate to large cell, or intermediate to large lymphocytes, and that's the only thing you need to diagnose large cell lymphoma. People get confused sometimes and say, well, anesicytosis and mesokaryosis, those are all criteria of malignancy we use to diagnose carcinoma and sarcomas. But lymphoma, you don't use criteria of malignancy. It's only if there's a predominance of intermediate to large lymphocytes, that's what is large cell lymphoma. But anyway, that was a little bit of a tangent. Other things that you can see in a lymph node are inflammation. So that can go hand in hand with lymphoid reactivity, but you don't always see inflammation with a reactive lymph node. That's another thing I see people say sometimes is, oh, it's reactive because I see neutrophils. That's inflammation, so that's kind of a separate thing. So in this lymph node, can you guys see pretty much right away that there are a lot of neutrophils in here? I hope that you can tell these are segmented neutrophils. It's tough to tell, but these here are small lymphocytes, and we've got them kind of scattered in here. They're a little hard to pick out in this picture because this is a really dense area, but the small lymphocytes are being crowded out by inflammation. So you've got a lot of neutrophils, and then these bigger kind of they're almost sheets in some area. These are almost looking a little cohesive, but these are macrophages, and macrophages are the most annoying cell in the body, in my opinion, because they can wear a bunch of different hats. But these are definitely macrophages, and sometimes they can stick together just like epithelial cells. We actually call them epithelioid macrophages in those cases, just because they're extra irritating. But so when I see this, you're not always going to find something infectious, but when I see inflammation like this in a lymph node, I'm definitely looking for anything infectious, just to make sure that I'm not missing something, that there's not something there. Now, if I don't see something infectious, that does not mean it's not an infectious process, but certainly want to look for anything. If you see that, that's a clue. So in this case, here is a different area of the lymph node. And what do you guys see?
Blasto.
Blasto! Yeah, good. So blasto was all up in this dog's lymph node. All of these guys are little blasto yeasts, and you can see they're big blue balls is what people call them, but they have a double contoured refractile cell wall is the boring way to put it, but basically they have these, the double contoured being the two lines here, and then if you focus in and out on these, they're very shiny, so that's what refractility is, so double contoured refractile cell wall, and then they've got the broad-based budding here, and these are actually, I'm sure you guys have had cases of blasto, and well, I hope you've tried to take some pictures of them and make them your phone background like me, but if you haven't, they're very difficult to take good pictures of because they're just 3D structures. So that's why all the rest of this is out of focus, because it's hard to get them in focus. But with that said, these are budding, and their buds are broad, so the broad-based budding blue yeasts. So this dog had blasto, and so as I'm going through, so we've got an answer, right? So we've got the dog has blasto. That explains its clinical signs. That explains its exam findings. And then as I was looking through the other lymph nodes, I was seeing some inflammation in those, seeing some blasto in those. And then I had one of the other lymph nodes that I was looking at looked quite different. And you can see the difference in these two lymph nodes, hopefully. And these are actually all lymphocytes in this lymph node. So all these guys are lymphocytes. And most of them are intact. So remember, we want to only evaluate intact cells in cytology. So I'm completely ignoring these blown apart guys here. These are just bare nuclei. But the rest of these, I can clearly see the cytoplasmic to nuclear borders. So these are all intact cells. And remember I told you that when you're diagnosing a reactive lymph node versus large cell lymphoma, you want to look at the ratio of small to large lymphocytes. And if you're not used to gauging size of lymphocytes yet, a small lymphocyte should be about the same size as a neutrophil to smaller. It should be either smaller or about the same size. A large lymphocyte is going to have, technically it's the nucleus, but it's going to be larger than a neutrophil. So what ratio do you see here? Is it mostly small lymphocytes or is it mostly large lymphocytes? Large. Almost all of these are large. We have a few smalls. So this here is a small. This is a little busted up small. This is probably a small. But the rest of these are all large lymphocytes. And this is what it looked like on the entire slide, on all the slides submitted for that lymph node. There was no inflammation. There were no blasto in that lymph node. So this dog actually had blasto and lymphoma. So bummer for him and bummer for the clinician that has to treat that. But I've actually seen this several times, and I'm guessing, I mean, as you guys know, there's theory that blasto, you certainly can be affected by blasto when you're immunosuppressed. It's not only in immunosuppressed animals, but certainly if you are immunosuppressed, then you're more susceptible to infection. And I guess theoretically, I would make a story for this dog probably had lymphoma first and then got blasto, but I don't really know. I mean, I can't prove that, but I've seen blasto lymphoma dogs, I think 3 at this point, and that had both. And so it's definitely possible. I actually posted this case on the pathology listserv, or I think it might have been the pathology Facebook page, like for pathologists. And I was like, yay, this is so exciting. Look, I mean, obviously not exciting for the dog, but exciting for us to have something kind of neat. And they're like, well, maybe it's just a really reactive lymph node. I'm like, come on, guys, this is lymphoma. You know, this is not, there's no question here to me. This is lymphoma. This is not a reactive lymph node. I'm not sure what ended up happening. Will, do you know what happened? That was Grace's case. I know she was not super thrilled when I told her the news, but do you know what happened to that case? Do you remember? No. Yeah. Yeah, I can't hear you, but I think you're saying she's probably dead. I think you're probably right. Yeah, oh, that's so sad to laugh about that. Yeah, that's sad. But this was a cool case, at least cytologically, and we had an answer. So that's a good part about this, is that we can at least go forward with that information and make good decisions for that dog as best we can to make her life as long as possible with these two not so great diagnoses. So yeah, that was her case. Any questions about that? Oh, well, hold your questions. I have some radiographs. I was too excited about the cytology. So these were, I don't know, I can't remember if either of these were her radiographs. I think the ones on the left might have been. So if you have a dog that you diagnose with blasto, you definitely need to take chest radiographs, because remember that these are dimorphic fungi, and so they are inhaled in a different form. They're not in the yeast form when they're inhaled, but then once they enter the body and they get into the body temperature, they transform into the yeast that you see on cytology. So they enter the body through the lungs and then disseminate into the different tissues. And I've seen blasto in tons of different places. I mean, it can go anywhere. We've seen them in testicles before. Seen them in like different species, in a alpaca, and like, you know, just a lot of different, in a monkey. So yeah, but it can do what it wants. But radiographically, you definitely want to look to see the extent of lung involvement. And these are just two different presentations that two different dogs with blasto had radiographically. This is another neat case that has sort of a parallel here. This was one where and that's supposed to say Emily, not Emil. There should be a Y there. But this was a case that I had submitted to me by Dr. Harrison, and this was a cat that had a toe lesion that you can clearly see here. And when they took radiographs of this, so the doctor on this case saw this toe lesion in this older cat and immediately had one potential concern. Does anybody know what kind of disease you might think about if you have a cat, especially an old cat with a toe lesion, like a deep toe lesion?
We have votes for lung digit syndrome.
Yay! Awesome. Lung digit. So lung digit syndrome is again, it's really cool as far as the pathophys of it, but not for the animal. But lung digit syndrome is pretty neat. It is it's where an animal has, and it's cats. I don't know that it's ever been reported in dogs. I'm pretty sure it hasn't. But it's an animal or a cat that has a primary lung bronchogenic carcinoma that then has a terminal metastasis to the toe. And for whatever reason, the tumor cells travel to the toe, to toes. I think you can have multiple, but I've only seen cases where it's been one, but I'm pretty sure you can have multiple toes. Cancer does what it wants, so I believe it could be multiple. But in this case, they were definitely concerned about that. It doesn't mean that every case you see of a cat that has a toe lesion is going to be lung digit syndrome, but it's definitely something to keep in mind if you see something like this. So they did their due diligence, and they did a radiograph. And I'm not a radiologist, but I feel fairly confident that this is the problem here, that this is a problem area. And they were like, well, here we go. This is lung digit syndrome, and they were all excited about it. And they still, which I'm so glad they did, because, you know, even though things really that quack like a duck end up being a duck, there are things that aren't, so we need to do our diagnostics. And they aspirated this toe. They didn't aspirate the lung lesion, but they did aspirate the toe. And this is what the cytology had. What is that? It's blasto yeast. So this was inside of this cat's toe, and these guys in the background that are out of focus are actually macrophages. They look spindle, but macrophages can do that sometimes. I only know that they're macrophages because there were others. There was tons of neutrophilic inflammation in there as well, and there were other cells that looked like these that were more rounded up like macrophages should be. So these are macrophages. If they also could be reactive fibroblasts, really they could be either, but they actually looked at the slide themselves and saw these big cells and thought, ooh, this is going to be scary. This is cancer. You know, these look scary. But they're not. I was able to find, that sounded so pretentious. I was able to find these. Yeah, thankfully I'm here to save the day, but no, I did my residency in Illinois, so I'm well versed in scanning for blasto. But yeah, so I was able to find these blasto yeasts, and this cat did not have cancer in its toe. This was a fungal granuloma in its toe. They did not aspirate the lung lesion, but I feel fairly confident that that's a granuloma. I mean, sure, the cat could have two problems. It could have a lung neoplasm, and then blasto in its toe, but it probably is a granuloma. And people think, well, that can't be right because blasto should do like the snowstorm pattern. And I've seen, and I'm not sure how many cases you've seen of blasto. I'm guessing a lot, but I've seen a few cases of cats in particular. I don't know if it's a cat thing, but that have like large focal granulomas, like singular granulomas on radiographs that look straight up like cancer. I've seen that a couple times.
Yeah, and we were treating a dog right now that had the similar thing, just solitary lung mass. We were all, kind of banking on carcinoma and separated and came back as blasto, and now he's being treated for that. So
nice.
yeah, blasto, especially in the area, is just like lymphoma. It does whatever it wants.
Yep. Yeah, I totally agree, and that's why I love cytology, because it doesn't always give you the answer, but when it veers you off of what you're originally thinking and gives you the answer, it's pretty cool. But yeah, it's weird how that you can have those big focal masses that really look like cancer and aren't. And this cat's Miravista urine antigen was obviously positive. Okay, case 3. And if y'all have any questions about that blasto or any comments or anything, chime in. Take a coffee sip, a little bite of your biscuit, and take a little break. Okay, so this is a 10-year-old female spayed cat, and this was actually the cat. This picture was sent to me for this case, and I love getting the gross pictures because it's neat to be able to correlate these things with what I'm seeing cytologically. But this cat presented with this proliferative tissue on his nose. So you can see this little tissue booger blocking up his nares, or his nair, singular nair. And so obviously they were concerned about that. And what would be one of your biggest differentials if this cat presented to you? Yeah, squamous cell carcinoma for sure. I mean, it's a white cat. It's got a lesion on its mucosal, on that exposed skin. That would definitely be the biggest concern, in my opinion, for this presentation. Well, it wasn't. So, big spoiler alert, we're not talking about cancer. So this was actually infectious, and this was the aspirate of that proliferative tissue. So does anybody know what this is?
Crypto.
And if you don't know exactly what it is, what kind of organism is it? I think somebody said it.
Crypto.
Crypto! Hooray! Y'all know your fungus. Yeah, so this is crypto. So, and not just because it's in the nose. Other fungal things can happen in and around the nose. But yeah, good job. So these are big crypto yeasts. And this particular picture is good because one thing about crypto is that one of its defining features is that they tend to have really thick, clear capsules, and they don't have that in this case. They have a little kind of more of a thin capsule, and some of them did have that thick, clear capsule, but most of them, it was a little more thin than you'd expect, and I just want you to know that that can happen. They don't always have that very thick, clear capsule that we learn about in school. So one thing about crypto to help you identify them is their size. They're really large. They are not small like histo are. They're sometimes about the same size as blasto, but one thing about them is that the yeasts vary in size. So where blasto is pretty uniform, all of them are going to be about the same size and shape. Crypto, you'll have ones that are big, and then you'll have ones that are small. So this one's big, this one's small, so the very variable size. They tend to stain blue to kind of pink sometimes. And one of their defining characteristics as well is the way that they bud. So remember I said with blasto they're broad-based budding, but crypto are narrow-based budding. So I really had a hard time with understanding this whole broad and narrow, I don't know, simple concepts to me sometimes just go over my head, but I finally get it, thankfully, as a pathologist. I finally understand the narrow-based versus broad-based budding, but the narrow-based, if anybody else is struggling with the budding, I don't think it's that hard of a concept, but if anybody else is, this is the narrow-based bud. It's like a string, so between the two parts that are budding, versus blasto, which it's I mean, it's just broad. It's bigger. The bud comes off in a bigger chunk. So this is thin. But yeah, so this is crypto, and one thing about crypto cytologically as well is that it usually won't elicit such significant inflammatory response as some of the other yeasts. So you can look around here and see there are really no inflammatory cells. These are just busted cells. Those are bare nuclei. We can't tell what those were, but no inflammatory cells around here. This is blood. And that's because they evade the immune system with that capsule. So they're good at hiding from the immune system. Oh, here's another picture. You can get a good view of that narrow-based bud. This was a different cat that also had crypto. And so one thing that we'll talk about when we think of crypto, or that we learn about, is the Roman nose. And so this guy wins the award for overachiever for developing a Roman nose. I mean, he really went for it and developed that Roman nose. And this poor cat is just, they aspirated that, and that was full of crypto yeasts. And but one thing I want to talk about is that just because you have an animal with a Roman nose does not mean it has crypto. It's definitely a great differential to consider, but there are other things that can cause nasal swelling in cats. Here's a different case. You can clearly see that he has this swelling here, and it almost looks like he's a little puffy in this area too, but it's this general swelling. And from what I remember, I think that they were concerned about crypto in this case. But that would be a fine differential to include. But remember, we need to make it a differential and not a diagnosis just based on this swelling. They went in and aspirated this swelling, and this is what they saw. So this is not this is not crypto. These here are all, it's stained kind of dark, but this is all red blood cells. And then these are the cells of interest here. Does anybody know what those are? They're round cells. They've got a little tiny bit of cytoplasm and a really big nucleus that's bigger than a neutrophil.
Big lymphocytes.
Yeah, large lymphocytes. Yeah, good. And the majority of them are large, pretty much all of them. I don't see any small lymphocytes. Maybe. That might be, I think that's blood actually. But yeah, so all these big purple cells are all large lymphocytes. So this cat had nasal lymphoma, and it had eaten through the bones of his nose, and that caused that external swelling. I also see that quite a bit with nasal adenocarcinomas. So after they start eating through the bones, and it can be anywhere in the face, but it can definitely happen in the nose as well. The history is usually, it's an older cat that had this sort of somewhat acute swelling, just generalized swelling sort of pop up in one area, and a deep swelling. And when you take radiographs, you can see that bone destruction. I'm pretty sure you can see the bone destruction. I would imagine you can if it's breaking through the bone in the face. But when you aspirate those, you can see neoplastic cells sometimes. Not always. Sometimes you just get snot because you're actually going into the nasal cavity. But yeah, so this cat had nasal lymphoma, not crypto. This is another kind of interesting entity that can cause nasal lesions or nasal kind of generalized swelling. I feel like the times I've seen it, it causes this little Pinocchio nose. It's not, I imagine it can be more of a swelling on the bridge, but it's almost like this little, the end of their nose starts growing out. It looks really ridiculous. But this is a nasal plasma cell dermatitis, and this is something that can or it doesn't always associate with plasma cell pododermatitis, but it can. And it's just an infiltration of plasma cells into the nose, just like you would expect with the plasma cell pododermatitis. And so in this paper, you can see that they said a firm and rounded swelling over the bridge of the nose. Oh, okay, so they did say that it can be on the bridge. It may be feline cutaneous plasmacytic reaction pattern. So I'm pretty sure that this is an immune-mediated situation, but it's just another differential to consider for cat nose lesions. All right, we got 2 more cases. Not going too fast, I don't think. This was, oh, I bet you guys can all see this? Is this in y'all's way? Oh, let's move that. Move you all down here. Okay, so this is Simba, a 6-year-old male neutered cat who presented with tachypnea and lethargy. And this is actually Simba. And he hated our technician, Gary. And this was pretty much the face that he made every time Gary approached his cage. And I'm pretty sure he attacked Gary. And that made it into my little newsletter at the time that I sent out to the hospital. It was kind of sad for Gary. But Simba was a nice cat. This was his face anytime Gary approached. But Simba, yeah, sorry, let me go back. So he presented with tachypnea and lethargy, so nothing too specific, but obviously we're going to be thinking about the lungs when we've got respiratory symptoms, and these were his radiographs. So, this is definitely not right. Does anybody want to describe these? More than not right? I can tell this is a problem, but all right, somebody be brave and tell me, not the radiologist in the room, what the pattern is here. I hear some talking, but I can't hear exactly. I feel like somebody's saying it.
Miliary?
Is that right? I don't know. Jaime, is that right?
Yeah, I mean, miliary gets thrown around quite a bit, but it originated from millet seed. So which I didn't know what that was, but if you Google a millet seed, it's like this really, really tiny seed, where these look like big seeds. So, I mean,
okay.
Some people may call it a miliary, but, well, my
so more like
is unstable, apparently.
Maybe like pumpkin seed.
Yeah.
We'll call it pumpkin seed pattern.
Yeah, we can coin that right now.
It's October. It doesn't feel like it, but yeah, I like it. Yeah, so this is definitely, there's diffuse lung changes here, and what differentials might you have for this? I mean, and that's a true question. I really don't know. I mean, obviously something infectious, but is there anything else you guys would consider if you see this at cancer, I'm assuming?
Yeah,
metastatic disease?
When cats get lungs this bad, it's honestly my least favorite thing, because the list of differentials, it's everything infectious. I mean, it's toxoplasma, mycoplasma, even bordetella can look this bad in cats.
Okay.
Yeah, of course, fungal disease and some of the bronchoalveolar carcinomas can spread along the lymphatics and look like this. So I hate when they pop up, because do all the tests.
Yeah, yeah. Would asthma look like this, or would it look different?
I've never seen asthma look this bad, because this is more, if you had to choose a pattern and where this was located, this is more in the interstitium rather than in the bronchial walls themselves. So I think I would primarily say that this is interstitial lung disease rather than primarily bronchial.
Gotcha. Okay. Okay. And don't be mad at this. So the top of the chest got cut off here, but yeah. So this is definitely was concerning, and so at this point they got super brave and they decided to do a BAL, and this is what was in the BAL. So this is a big macrophage, and then these are what? Histoplasma. Excellent. Histoplasma. I was so excited when I looked at this BAL. This was super fun day. So, I mean, we see histo occasionally, but I don't know that I'd ever seen it in the BAL before that I can remember, but in any case, it's just fun. Seeing infectious stuff is fun, because there's the answer and you're pretty much done, unless you also have lymphoma like Pepper did, and then you're not done. But yeah, so this was histo, and histo are, contrary to blasto and crypto, are very small. So these guys are packed into a macrophage, and you can see them, compare them to the size of these degenerate neutrophils here in the background. They're very small. Blasto is going to be more the size of this neutrophil. Blasto and crypto will. So they have this really thin, clear capsule. That's something you definitely want to see if you're going to call something histo. And then they have this sort of basophilic internal structure that can sometimes look like a crescent moon. There's not a good example in this one, but I'll show you in a couple pictures. But this Simba had histoplasma, and that was what was causing his lung changes. So that was a exciting find. I think that he decompensated. From what I remember, I think that this was a little while ago, so I can't remember all the details, but I'm pretty sure he did fine for a while, and then he continued to get worse, and I think he was euthanized at some point. So sad for Simba. But this was a different case, not Simba. Sorry, my formatting went off there, but this is actually was the background on my computer. I finally switched out for my child, but this is a beautiful picture of an intestinal mass in a cat that had histo, and it was a mass. It was not just like a little, whatever. It was a discrete mass, which was a fungal granuloma, filled to the brim with these histoplasma yeasts. So again, don't just assume something is cancer. Not that this is necessarily much better, but it's not cancer in this case. It was histo, and these are big macrophages just filled with them. This was another cat, and this was a spleen. And when you have a cat that has an enlarged spleen and, fever, just not doing well, and you can't find another cause, aspirate the spleen and look for histo, because it tends to do that. It can cause splenomegaly in cats. In my experience, they're really hard to find in those cases. This was not at all like that intestinal mass. I was at the very end of looking at this slide, and I was about to give up and looking for a cause, and I found this one macrophage that had this one histo yeast in it. That was all that was in there. But based on that one, I felt confident that this was histo. It fit with this cat's clinical signs. He had a fever, splenomegaly, yeah, so this cat had histo, but it's definitely something to consider when you have generalized splenomegaly in a cat, and fever especially. There is a little closer, and an arrow if you can't see it. And then this is also a cat. This is cat histo day. Histo does happen in dogs too, but this was actually joint fluid from a cat, and this was really cool. I've never seen this before, and I've never seen it again, but this was super duper inflamed. This joint fluid was just so inflamed, and so of course you're going to look for infectious stuff and make sure you're not seeing bacteria, which that's what I was looking for, but I came across this macrophage that had these two histo yeasts inside of them. So this cat had histoplasma, and I don't remember all the details of this one as well, and I don't always get the details with all my cases, but the cat had a joint effusion. So obviously that's why they aspirated it, and they were very surprised, as I was, to find histo in the joint. All right, so this last case is one of my faves. This was a cat that came in on our emergency service and was seen by my husband, ER extraordinaire, Will, who came in and said, hey, he came in my office and was like, hey, this cat has something weird going on with his eye. I mean, he used the technical terms, but to me, this is something weird going on with the eye. And we were talking about this case, and this is actually his eye. And we were like, well, what should, he was brainstorming what he should do with it. And he ended up just lightly, I think this is right, Will, didn't you just lightly touch a swab to that ulcer?
Yeah.
Hello? Yeah, okay. Huh? Oh, I can't hear you, but I think you said yes. So he just, yeah, okay, good. So he just lightly touched a swab to that. There's an ulcer in there somewhere. I think it's here. You guys are better at this than I am, but I think this is from a stain. So he did have a corneal ulcer, and he put a swab on it, and he just rolled the swab on a slide. In talking to our ophthalmologist, that's not really a common thing to do, to just swab an ulcer. So I'm not saying necessarily to do this or not, but that's what we did. And just to get back up a little bit, so this cat had this going on. I think it was relatively acute, right? It wasn't going on forever. Yeah, it sort of started, and he brought the cat right into emergency. So this is what we saw cytologically from the swab that he did of that ulcer. And there was inflammation in here. These are neutrophils that are squished. This was a neutrophil at one time. It's blown apart now. This is a blown apart cell. This is some debris. So there was inflammation on this cornea, not surprisingly, because it had a corneal ulcer. But I was seeing a few of these things that I was like, what the hell are those doing in there? So these are little protozoal organisms, and I've never seen this in this particular location. So I was really excited and really perplexed also, but these little guys have this sort of dark blue nuclear structure here, and these look a little elongated, but they can have this football look to them too. And this was toxoplasma. So when I saw this cytology, my first thought was, well, these look like protozoal tachyzoites. That's the word I'm looking for. And there are a couple different protozoal organisms that can look like that. So toxoplasma is one, Neospora is one, Haemondia, a couple different kind of obscure protozoal organisms. But of course in a cat, the first thing I'm going to think of is toxoplasma. So we did antibody titers, and they were positive. You can see here the IgM was positive. So this cat had toxoplasma, and presumptively these are toxoplasma. You know, the cat has toxoplasma, and we see these organisms. I'm going to put 2 and 2 together and call those toxoplasma. The interesting thing about this is that these are, you know, we looked in the literature, and there are a few cases of toxoplasma-associated KCS in dogs, really old cases, and I hadn't seen anything about it in cats. And the question was, you know, was this a secondary finding? Was this the cause of the cat's anterior uveitis? You know, what is the primary pathology here? And so the question was there something going on back here that had nothing to do with those little toxoplasma organisms on the corneal surface? The cat ended up having his eye enucleated, and it came back as severe lymphoplasmacytic anterior uveitis of unknown etiology. So I talked to the ocular pathologist in this case and was like, hey, what does that mean? Because, you know, eyeball pathology is a whole nother world. But she said that can happen. Basically, they just don't know why that happens. Lymphoplasmacytic anterior uveitis, it can be associated with infectious stuff. It can be associated with immune suppression, with, you know, just anything. It's just kind of an entity that we don't really understand all the causes of. And in this case, we didn't have a clear cause of it. The cat did not have any neoplasia in that eye, because one thing we were concerned about was, is that lymphoma or something back there, and that he's immunosuppressed. And no lymphoma, no neoplasia in this case. And so it's unknown if his toxoplasma was associated with that anterior uveitis or not. I mean, I would assume they have something to do with each other. But and I forgot to mention, before the eye was enucleated, he was put on clindamycin to see if that would, and probably some other meds, but he was put on clindamycin for his toxo to see if that would help resolve anything, and it obviously didn't, and I'm pretty sure it just got worse, and that's when they enucleated. He came back several months later, I think, probably, and his other eye was doing the exact same thing. So his other eye just started rotting off, and we tried to do the swabs, and actually the ophthalmologist did a scrape of the corneal ulcer on the other eye to see if we could find any organisms there, and we didn't find any. That doesn't mean that they weren't there. We might have just got lucky the first time, or maybe they weren't there. You know, it's kind of a mystery. But that eye, I believe, was enucleated as well, and I'm not sure what the histopath ever came back on that one. I need to follow up with that. Do you know, Will? Okay, yeah, I'll need to follow up with Eric on that one. Just a few other cool pictures. This is a different case of a cat with lung pathology. They aspirated the lung, and these are all, they look a little bit different, but they have the same general shape, that little banana or football shape with that dark nuclear structure there in the middle. So these are all toxoplasma organisms in this cat's lung. Oh, that was abrupt. I thought I had one more slide, but yeah. So this cat had clearly had protozoal infection that was then diagnosed as toxoplasma based on the titers. All right, that was an abrupt end, but does anybody have any questions about any of that, or any thoughts, or any cool cases you've seen that you want to share in the last couple of minutes? I know it's early. It's never too early to talk about cytology, guys. All right, well, good. Well, if you guys have any questions or comments or anything, feel free to email me. I'm not sure if you guys have my email, but it's kate.baker@antechmail.com. And if you didn't jot that down and you need to talk to me at any point, then you can get my email. Jaime has it, Will has it. So feel free to reach out to me. If you guys ever want to learn more about cytology, I have a Facebook group, the Cytology Coffee House, that you can join, and it's been a lot of fun talking to people about their own cases and stuff in that group. So that's a good resource if you're just dying to know more about cytology. But yeah, thanks again for having me. This was really fun, so thanks for participating too. I know I can't see you and you can't see me. Yeah, okay, good. Well, until next time, I suppose. All right, have a good one. Bye.
Bye.